next speaker, Dr. Charles Wang Ce, who came to us from Chicago. He's currently the director of the epilepsy service and in charge of monitoring national physiology. Dr. Wang actually went to University of Illinois, Chicago for his residency and did the fellowship over there too. And came to Chicago for his professional development, and over the years became the senior educator for the med school as well as in Chicago. Please welcome Dr. Wang for Migraine Update 2025.
Okay, thank you very much. I thank Kana for invitation for giving this talk, and actually this more friendly discussion, exchange our information. I prepared for 2 days talk. I tried to get as fast as possible and get it done in 30 minutes, maybe 25 minutes, okay? All right. So migraine, I have no disclosure. So migraine, the word is, I think you can point this. Came initially from Greek language, hemicrania, and then evolved to hemicrania, to Latin. And French people very smart, so they put this hemi, get rid of he and get rid of a and add a I, so it became a migraine. And then English people just adopted. So that becomes migraine, this word. So it really means hemicrania or hemi headache. So you see, hemi, half headache. 我们中国人叫偏头痛。Okay, I'm gonna skip this one. We don't have to talk about this epidemiologist. The simple thing is that it's very common. All right, I think we can skip this one. The four phases of migraine typically start with premonitory symptoms, then aura, then headaches, then prostrum. But doesn't mean that everybody will be getting all four stages. But generally speaking, they have those symptoms. We don't have time to talk about that. Diagnosis, I think we can skip. So for migraine without aura, so you have to fulfill with this criteria: history, physical, and then without aura, at least 5 attacks, fulfill with B, C, D. I think we're gonna skip those things. Migraine with aura and at least 2 attacks, fulfill with B and C. Differentials, of course, migraine differentials have to first think about other primary headaches, such as tension headaches, such as trigeminal autonomic cephalgia, such as cluster headaches or stuff like that. Secondary headaches, I think, is also important to make sure rule out structural lesions or headaches secondary to infection, bleeding, stuff like that. And also have to differentiate to other episodic symptoms such as TIA, seizure, syncope, and vestibular disorders. Also, some retinal pathologies, visual hallucinations related to neurodegenerative changes or psych disease, and causes of encephalopathy, etc., and brainstem ischemia, etc. 2 concepts, I think everybody knows it, I don't have to, but I think it's because clinical studies sometimes use this language. Episodic migraine is migraine that have 0 to 14, less than 14 per month. And if greater than 14 headache days per month, then called chronic migraine, because episodic migraine can transform to chronic migraine. Treatment. I think this is probably more important for us. Treatment including acute, abortive treatment or symptomatic treatment. The ideal acute treatment should fulfill with this thing. It should be ideal. Hopefully we can achieve that, but not always we're able to. So should be treat rapidly and complete relief of symptoms and associated symptoms. Again, we'll talk about ideal or our goal, ultimate goal. Prompt return of function and reduction in attack-related disability and effectiveness at first dose, and with no recurrence of headaches and limited need for repeat treatment. Wow, sounds very hard to achieve, right? And minimal side effects and cost-effective, easily available. So those are really ideal situation. And okay. The principle, universal principle of acute treatment also include should treat early when pain tends to be very mild at early stage, and should match the medication type to attack severity. Use maximum dose, consider non-oral formulations, and use combination treatment and treat nausea. So some evidence-based option for acute treatment of migraine. I think this is from a continuum. So this column are the medications as established as effective, and those evidence are moderate to high or low to high, but do have a strong evidence to support the effectiveness. So those are triptans, dihydroergotamine nasal spray, and CGRP like G-pens, lasmiditan, over-the-counter non-steroid medications such as aspirin, ibuprofen, naproxen, and prescription of NSAIDs such as celecoxib, etc. And this side are the medications that has sort of probably effective. So evidence may not be so strong, but we do use really commonly. NSAIDs, this NSAIDs, magnesium, opioids, medication, ergotamine, caffeine. I think we use quite a lot. Antiemetics and acetaminophen. Okay, so we're talking to the severity of treatment, of acute treatment of adult patients. So for mild headaches, so typically those are from, I think, from up-to-date or continued, one of the experts actually adopted from them. So mild attacks not associated with vomiting or severe nausea, maybe starting with analgesics. Or combination analgesics and acetaminophen. For attacks unresponsive to those, may add triptan. And combination of NSAIDs and triptan appears to be more effective. And with some nausea, vomiting, we can definitely use oral or rectal antiemetic medications can be added. What about moderate to severe attacks? If not associated with vomiting or severe nausea, first line still triptans, with or without NSAID. If not respond to above, we can add a CGRP antagonist and or lasmiditan. When complicated with vomiting or severe nausea, severe migraine attacks can be treated with antiemetic drugs. And actually, one of the principle is combination therapy and antiemetic therapy at the same time. Well, we're gonna have to briefly mention about the CGRP's calcitonin gene-related peptide. It plays a key role, now we understand, in migraine pathology. This is a 37 amino acid neuropeptide. It's expressed in the trigeminal ganglia nerves, and it's a potent vasodilator of cerebral and dural vessels, and it appears to mediate trigeminal vascular pain transmission from intracranial vessels to the CNS, as well as a vasodilatory components of neurogenic inflammation. And so the researchers show that stimulation of trigeminal ganglia induced release of CGRP, and the CGRP infusion can trigger a migraine attack. So the bottom line is CGRP release plays important modulatory role in migraine headaches. So this is just exactly telling what happens, CGRP. So this is the terminal of a neuron. The dot is a CGRP released to the junction and binding the receptor. This normally, so the ligand CGRP bind to CGRP receptors and cause cascade responses for further inflammation. Now, the CGRP has two categories. One is big, is monoclonal antibody. So 2A is monoclonal antibody against the receptor of CGRP. 2B is the CGRP, is a monoclonal antibody bind to the ligand, CGRP ligand. So either way, it can block the action of CGRP. Now, another one is GPAN. A GPAN is small molecule, and they bind to the receptor and seem to block the reaction. So what about for status migraines? Severe intractable migraine attacks or status, talking about lasting about 3 days, those kind of thing. May try combination of IV fluid, and we all know that. I think we can skip that. Maybe just add some antiemetic medication or DHE or valproic acid or dexamethasone, or may require admission. Now, emergency setting, I think we can quickly go through that. Migraine in emergency setting generally have severe attacks, no doubt about that. In many cases, they failed multiple routine medications. So you can try anything: sumatriptan, antiemetic medications, DHE, or our ER really like this cocktail, ketorolac, things like that, so on. Okay, I think we can go next. So acute treatment migraine. So those are individual some research data supporting that medications useful for migraine acute treatment. I think we can go quickly. So those are aspirin and NSAIDs. Different studies support their effectiveness, and even acetaminophen, it showed an effective abortive agent in some patients. Can be used in combination with NSAIDs or caffeine to enhance the effect. So let me go through that. Okay, so that's NSAID and acetaminophen. Now the triptan, we all know that it's a serotonin 1B1D agonist as effective for the acute treatment. So those are a list of the triptans I think we all know, and those are the dosage, and those are the maximum dose we can use, and some important things we need to remember that drug-drug interaction. That's from up to date. Okay. Now, interesting thing is that even last year or 2 years ago, when I in consult in OB, and the doctor, well, a pregnant lady got severe headaches. Can I use sumatriptan? I said no, we generally don't recommend. And she said, well, are you aware of some studies that we had in our OB/GYN territory, and we all recommend, okay, which is one of the neurologists said, okay. Okay, I would say, well, we don't have recommendation for that, so I don't recommend it. This recent news in the neurology today, and it says, safety option during pregnancy. So accumulated evidence for sumatriptan suggests exposure to this drug does not increase the risk of birth defect, make it a good option to treat migraine during pregnancy. Dr. Kinston. They look at so they have the most registry data for sumatriptan, just by virtue of the fact that it was the first triptan. We have not found any teratogenic effect, which in my experience is the first question that people will often have. And there's not a clear signal for adverse pregnancy outcome. So that's something we keep in mind in case they ask us. We should know that. Another option is the botulinum toxin, for which very reassuring data indicates safety during pregnancy. That's review concluded prevalence of major fetal defect among live births among pregnant women use this is consistent with the rate reported in general population, so no increased adverse problem, stuff like that. However, we thought the CGRP may be safe in this situation, but we really don't have data. So newer agents to treat migraine, such as CGRP, should be discontinued at this point. We don't have any data support its use during the pregnancy. Okay. How much more time do I have?
So we have another 6 minutes.
I get that. Okay. So we're gonna. Again, this is acute treatment, DHE, GPANs, and lasmiditan. Those are dosage and maximum dose, and some important interactions, stuff like that. This is a new, relatively new GPAN. It's the first nasal spray GPAN for acute treatment. It's a GPAN, small molecule against the CGRP receptor. It can be used acute treatment, just one puff, 10 milligram, and should be good to go for patient. This one, lasmiditan, is a 5-HT1F receptor agonist. Seems to be quite effective, but side effects may be a little bit more like drowsiness. But it can be used for if triptan contraindicated, such as cerebrovascular disease, elderly people with heart problem. Maybe you can consider it. And cause drowsiness. All right, we're going to skip this. So other like neuromodulations also being used for acute treatment. So many different neuromodulation. You can always Google it. All right, now, other than acute treatment, one of the most important things nowadays is how to prevent migraine. I'm going to skip this. So frequent long-lasting migraine attacks cause significant disability and contraindication for other acute treatment or failure of acute therapy, and so on. Those are common indications. And this may be a good guideline for us. So prevention offered or prevention considered. So this is headache days per month and associated with degree of disability. So if say patient only have 3 headaches per month, headache days, but severe, so should offer prevention. And if patient has 6 headaches per day, but none of the disability, but also can be considered for preventative treatment. But prevention considered just -1, so it's less than 1 of them. The same severity, so it's still considered prevention. So in other words, if you have 2 headache days but with severe headaches or disabilities, still consider prevention. Okay, I think those are the main goals. Those are first line migraine prophylactic medications. We all know that. And the depressant beta blockers and the convulsant CGRP antagonist, and some those monoclonal antibody and the GPANs. Choice. Second line. So patient, if they have contraindication to first line or have inadequate response to first line, certainly we can consider for other second line therapy such as antihypertensive, gabapentin, and other options. Again, we all know that, but we emphasize valproic acid should not be used for female for childbearing potential. All right, those are summary of migraine prophylactic medications. I think we should just give this beta blockers, calcium channel blockers, we all know that. Antidepressant and convulsant. And CGRP. So this which emphasizes this is relative neuro stuff for last 5 years. So they have significant role, CGRP, in the neural inflammation and pain transmission. And we have 2 different, one is monoclonal antibodies, another is small molecules against the GPANs. All right, I don't think we have time to go over each individual medication, but certainly it's up there. You can always Google it. I think we're gonna pretty much stop here. Okay, I think we're gonna stop this stuff because we're gonna have limited time. I told you it's 2 days data. Okay, I'm gonna stop here and.
Thank you so much, Dr. Wang. We have time for a couple quick questions. Anyone? Burning questions?
Yeah, I have one. Actually, it's more like a comment. You know, in medical practice, one of the top 1 priority for us, not priority, but one of the most important thing for us to consider is the liability. When we manage a pain patient, including migraine, basically the rule is no medication. And I don't care. It's a Motrin, some triptan, GPAN, or steroid, anything. Pretty much all the pregnancy patients, we want to be 0 medication. Except one. For many years we say, well, Tylenol is a category B. It's very safe, very good. But recently President Trump said, no, it causes autism. And then he take away this authority from us. The day he announced that, actually I feel very sad. I said, now what are we going to do, Because the goal is 0 except the Tylenol. So what's your comment about that?
Thank you for that. I was thinking just 5 minutes ago, what are we going to do with the patient during pregnancy? Maybe sumatriptan. That's because large registration data really supported it. It doesn't have really major problem.
There's no autism data.
That's right. There's no data. That's a good question. What about you guys think? I mean, anybody?
guarantee 100% it can cause autism. Because the autism patient will find, oh, my mother took triptan. So this patient will say, oh yes, they take triptan, they all link it. Just like symptom retirement.
Well, talking about tetanus in headache, maybe you can consider Neuropark with steroids or with lidocaine.
Use the microphone correctly, please.
Or neuromodulators. And Botox.
Well, we don't have
Autism data. So.
I think the acupuncture is very effective. Yes,
Okay, it doesn't have autism data.
acupuncture, there's a study, this was published about 15 years ago now. It's a cumulative, not a double blind, published on this very small neurology journal. They accumulated the analyzed data, 135,000 patients. They found actually it's more effective for the prophylaxis, even though they use a lot for acute. In long term, it is better than any of the treatment we use. If you come out of the journal, I have not looked back yet. I was so amazed. Somebody analyzed more than 130 patients, 130,000 patients. So acupuncture, I believe, is very effective.
I wish one day we'll elect James Wang to be the president of this country. One last comment or question for Dr. Liu, because we turned off his last request.
I'm sorry, I always give the probably stimulating come on to questions. I appreciate your review about the challenge questions about acupuncture for migraines. So in terms of the clinical trial and the individual experience, probably quite different. How do we definite the effect of the treatment? If you say yes, I agree. If it depends on the treatment or in the clinic, if it depends how long the different. In German, I think probably it's in German or internal medicine, about 20 years ago, there's a report. In terms of acupuncture or different pain management, including headaches, including lower back pain. My interest in lower back pain because I'm a neuromuscular specialist. It says yes. If you say yes, that means they put acupuncture in, pain will be reduced. The good thing they will say, avoid another chemical medicine, the side effect. They say no, is that when patient walk out from the door of the clinic, the pain come back. So that means how long it will last? The compare with they do not do placebo, they use Motrin. They say the effect is comparable for the Motrin. The problem is you take one pill of Motrin or that will generate the pain. You can last it for several hours, or you can use acupuncture for pain for that 20 minutes, you continue stimulation, or stimulate for 4 hours to achieve the same problem. So the question is yes, for the time being, no is also for time being as also for your definition. Thank you.
Can I have a comment on this? Acupuncture, actually for the pain control, there was a double-blind study. This is more than 35 years ago. Most of us probably don't remember. I did not know until my mentor told me when I was a pharmacology graduate student. He said somebody did a double-blind study for acupuncture for pain control. It's very difficult to double-blind. How could you do the double-blind? NIH sponsored a double-blind study. The study was acupuncture for everybody. One group, and I think more than one group. One group take central nerve block, central opioid block. The central opioid block group, I think it had no effect. So that means it works centrally. So, and after an analysis said yes, it works centrally through the central pathway. That's what they did the double blind study. Somebody from NIH very smart, they want to figure out.